Good evening, all. Tuesday night, 7 p.m. You know the drill. Q's and A's going on all over the shop here. It's the 30th of January, unless I'm very much mistaken. And I think we can do away with the Happy New Year's and just get straight into it, can't we? So hope everything's going okay in your week slash month slash year. I'm very excited to have some questions on. Now my setup with a bendy phone, I can't see what's going on there, but I can kind of get an idea that if there's a question on the Instagram, but the Instagram has provided me with 2 responses to my sticker, which is pretty exciting. So I'll do those first. I have also got other questions to go through. So I'll start with these ones. So can you have a tummy tuck if you have internal scarring from a cesarean section? Yes, you can. In fact, it's quite common, as you might imagine. Quite a lot of people having tummy tucks have had children, therefore they quite a large proportion of those will have had a cesarean section. So it's not unusual. And sometimes I see people who've kind of had 2 cesarean sections have got 2 scars. Never quite understood that, because if you're going to give a scar in the same area, then we would tend to excise the scar that you've got. So if you have a cesarean section scar, the idea is that we go below the cesarean section scar and excise the cesarean section scar with the tummy tuck. So you end up with 1 scar, albeit longer than the cesarean section scar, but the cesarean section scar disappears. But it's completely fine to have a tummy tuck if you have got a scarring on your abdomen. And actually the cesarean section scar is fine. Only slightly more complicated if you have what's called a classical cesarean section as opposed to a lower section cesarean section, which is your I was about to say your classic one, but obviously it's not, is it? Because it's a lower section. So the lower section one is the one which goes horizontally in your sort of in line with in your underwear, which is your normal cesarean section. But certainly if you need an emergency, or rarely they will do it straight up and down, or if you have to have an abdominal surgery for another reason, if you have a straight up and down scar which goes from your belly button down to your pubic area in a sort of vertical orientation, a little bit more difficult, but still absolutely fine. The problems come in terms of scars on the abdomen and tummy tucks is for scars in the upper abdomen, so scars from the belly button up to your rib cage. In the old days, they used to take gallbladders out with what's called a Cocker's incision, which goes along your rib cage. And that was a real issue if you were considering having a tummy tuck and you got one of those. But no one has them anymore because everyone has their gallbladder out with a laparoscopically, with a telescope, with the keyhole. So very rare to see those scars anymore, but certainly scars in your upper half of your abdomen, so from your belly button up, they would be an issue. But scars in your lower abdomen, so things like appendix, things like these cesarean scars, absolutely fine, no problem at all. I mean, when you do the surgery, you have to go through scar tissue, which can be a bit of a thing, but it's fine. It's not an issue. So yeah, that's something. Thank you for that sticker question. And the other sticker question, if you I've written it down. I'm not sure how I can see the sticker question at the same time as doing the thing. I haven't got to that level of Instagram prowess. If you were to explant, do you recommend a lift at the same time or waiting? If you were to have an explant, so if you have to have your implants removed, do you recommend having a lift at the same time or waiting? So that's a good question. And it's one of those ones which many of the questions fall into this category. I have to say, kind of hard to give an answer directly. But I do have a view, and I do, as with everything, I do try and discuss with patients to try and get a view together as to what we both want to have happen. But broadly, if you need a lift now, so if we have a look at your breasts and your breasts are sitting low and you kind of need a lift now, then I would be thinking about having a lift at the same time. So I've got no problem with doing a lift at the same time as an explant, as removing your implants, because if you kind of need a lift when you got your implants in, it's going to be even worse when you have those implants out, because you can have even less volume, and that's going to make your breast sitting even lower. The problem comes when patients maybe don't particularly need a lift now, or are maybe borderline for it, but not really bothered about the shape, and they just want to get rid of their implants, because the breast shape will be worse when the implants are removed. And so the question is, how much worse will they be? So am I better off having my lift now or waiting? And that can often be a difficult one to answer, because it's almost like the perfect crime if you did the lift now, because you never know how bad you're going to be, because you do the lift at the time of the explant. And I think there's a lot to be said for doing a lift at the time of the explant, because it's one operation. But having said that, if you kind of, I think the question was, what do I recommend type thing. And I guess if I'm my view, and I try not to impose it, but my view is, I would, if it's really on a knife edge, I would probably be saying, look, why don't we just see what it looks like, to avoid the scarring, to avoid the risks associated with a lift, because it might look okay. And in my experience, when you remove the implants, it kind of often looks better than you might think. I don't kind of want to say that to all patients, because sometimes it won't, it might not look better than you're going to think, but it often does look surprisingly good, and you think, oh, it's going to look terrible when I've had my implants out, it's going to be all saggy and everything, and actually it does tend to respond. I mean, it depends on who you are, depends on your skin quality, etc. But as a general rule, it often does kind of look okay. So if you're not that bothered about the shape and you just want to get rid of your implants, I think there's a lot to be said for just doing one problem at a time, saying let's get rid of the implants and let's have a look what the shape looks like. Having said that, if you've got a bit of a droop already, and if you are quite bothered by the shape and say, hold on a minute, I'm not going to pay all this money to have my implants out and it looked worse than it looks now, then there might be a case to say, look, let's do a lift at the same time. So it's a hard one to kind of give an answer to everybody. It is, as with all these things, a case-by-case basis, but it is judged but basically on how you kind of look now. And some people are like, need a lift, some people like definitely don't need a lift. It's always those ones in the middle which are a problem, who don't need a lift now, but when you remove the implants, are they going to look worse and they're not going to need a lift? So that's the problem with this whole party. It's, you never know, we never know. So we have to kind of like personally I try and kind of like discuss with people so that we're hopefully on the same page, and we're hopefully trying to make the best decision with the information we've got right now, which is never perfect, because we don't know how your body's going to react when those implants come out. And it's not only initially when the implants come out, because often the skin will recoil in the coming weeks and months, so you have to give it a bit of a time. So it is a difficult one to know. No one will know before those implants come out what your breasts are going to look like. We can kind of have an idea, but no one knows. The more you get on in life, the more you realize no one knows anything, really. We're all kind of just saying usually this or usually that, or the chances are this is going to happen, whether you're the weatherman or whether you're the plastic surgeon. We share a lot of traits with Michael Fish, Michael Fish and myself. We've got a lot of, we can't always get it right. We try our best to predict the weather, but we don't always know whether it's going to rain tomorrow. We can say good chance, and often we're right, but not always. But anyway, enough of my problems. I'm just going to have a look at this. What's it? Oh, is there questions? I've got to scroll. Okay. You wait. Oh, I waved at Peony. What do you think about teardrop for B cup enlargement? Right. Oh God. What do you think about teardrop? Oh heck. Right. Oh, that's better. Oh, that's good. Does that look all right? What do you think about teardrop for B? That's a real. Oh my. That's one of those questions which is kind of like impossible. That's an impossible one. I don't know where to go on that. Teardrop, I think. Well, So what do I think about teardrop? Yeah, I think teardrop are good, particularly if you've got no volume, if you're completely flat. B cup enlargement, that's obviously not a huge cup size, so it's well, okay, I'll answer it. Yeah, sounds reasonable. Teardrop for a B cup enlargement, that sounds reasonable. Yeah, I think that sounds reasonable. Hard to kind of be too. I don't know if that's helpful. Is it helpful? My keyboard has come up. How do I get rid of my keyboard? Oh God, sorry. Oh heck. Right. How do you make the key? Right. Anyway, let's just keep going. So teardrop enlargement. Yeah, B cup for a teardrop enlargement sounds reasonable. Leave it, Jackie. I thought someone else said. Maybe not. Right. Let's get back on track. I've got the keyboard up, and it's gone. Right. Good. So. Right. So, in terms of what do you think of teardrop GB cup enlargement? I've got this question here that I've got from a patient might also kind of help enlarge on this, because I get a lot of times people kind of want to know whether to have a teardrop or they want to B cup or whatever. So and it's really, this whole implant game is not very precise, to be quite frank. And let me explain. Could you explain the positive and negatives of low profile and moderate profile, please? I understand the breast implant is chosen based on the diameter measurement first and then profile type second. Are there any differences other than projection? For example, is the creasing of the implant more evident in a low profile versus a moderate profile? Creasing of the implant. I'm not sure what creasing of the implant is. Does that mean rippling of the implant, maybe? Or does that mean that when you get a bit of a crease, when you get a bit of a capsule forming around the implant, which predisposes to rupture? Not sure what that means, but I guess it doesn't matter. Well, it does actually, I suppose. So if that's rippling, if you mean creasing, if you mean seeing the creases of the implant through the skin, in general terms, for the given base width, so you're absolutely right, the base width is the first measurement. For a given base width, a low profile implant is going to be smaller than a moderate profile implant, and a low profile implant and a smaller implant is going to be easier to cover. You're always looking for a balance between the amount of implant and the amount of breast tissue you've got. Obviously, the breast tissue you've got is set. That is a set amount, and the implant volume is changeable. You can decide what size of implant you have. So the bigger the implant you have, the more implant there is in proportion to the breast tissue, the more risk of rippling, which is, I don't know if that's what you mean by creasing, but anyway, so the more risk of rippling, the more risk of being able to see it, the more risk of being able to feel it. So everything else being equal, a smaller implant is going to be better in terms of being able to see it or feel it or getting complications like that. Having said that, you have to get the size you want, so there's no point in getting a really small implant so you can't see or feel the edges of it and it doesn't give you the effect that you want. So as with all these things, you've got to get the balance right, because you don't want to, you want to have a size that you feel is right. But if you're asking the question, is rippling worse with a low profile than a moderate profile? Well, for a given base width, as I say, the low profile is going to be a smaller implant, so there's going to be less volume of implant to hide. So yes, there will be less risk of rippling with a low profile implant compared to a moderate profile implant of the same width, because it will be smaller. There's this same patient. I think I know. Is it coming up later? No. So this same patient has also sent me a video of someone talking about profiles of implants, and I think she was saying, how does this work in terms of my profile, because we were looking at a specific profile for her, and this is a patient, this is a surgeon talking about different profiles, and the problem when you talk about different profiles is that you kind of have to talk to, if you're going to look at photos of people with the different profiles, you kind of have to look at photos of patients that the surgeon has operated on using the profile of the make of implant he's using. Going a bit around the corner, around the houses here, because the surgeon who is speaking obviously uses Mentor and uses Motiva implants. So Mentor have moderate, moderate plus, high, and ultra high profile. Motiva have funny names: low, demi, full, Corsa. They call them funny names. Some companies have low, moderate, high, extra high. So they don't have a moderate plus, but they do have a low. So, you know, the names vary is the point. So the names kind of don't matter, because the dimensions matter. And for instance, I was talking to a patient a while ago, and she was saying, "Oh, I'm not sure whether to have a moderate or a high profile implant. Which one shall I have?" And I'm like, "Yeah, have a think about it. We can go over it, etc., etc." And then she come back and said, "Oh, I cracked it. Moderate plus. I have a moderate plus." And I'm like, "Hold on a minute. No." Because in her mind, she thought she cracked it. She got, hold on, I don't know if I had a moderate or a high. And she's gone away and found out that there's a moderate plus. I'm like, well, a moderate plus is a different make. The moderate plus is Mentor. Mentor have a profile called moderate plus. And the implants we were talking about were, I can't remember what, maybe say Polytech, which do low, moderate, high, and extra high. And actually, if you look at the dimensions, the moderate profile Polytech had more projection than the moderate plus Mentor. So just because it's called moderate plus doesn't mean it's going to have more projection than a moderate in a different make. Obviously in the Mentor make it does, and similarly, just because it's called high, a high profile in one make might have different projection to a high profile in another make. There's no standardization for what they're calling high, what they're calling low. And as I say, Motiva don't even call them low and high. They call them demi and Corsa and full and all these other names. But what you got to do is you got to say, so I show slides, I say, that's a low, that's a moderate, that's a high, that's an extra high of the implants that I use. And that's the sort of look you get with the sort of profiles of the implants that I use. So I'm all for people doing research. In fact, most of my patients do research and are very well informed. And I think it's very important to be well informed. But you can tie yourself up in knots by doing too much research, because you then get into this realm of like, what, low, moderate, demi, Corsa, where's mine? I'm like, doesn't matter where yours is, doesn't matter low, moderate. We've looked at the photos, you've liked the moderate profile, the width is this, therefore, you know, for that width, for that profile, that implant is one that fits your frame. And like, it's all on the measurements, and it doesn't necessarily transpose to other companies. When you look at, say, a moderate plus isn't necessarily between a moderate and a high in another company. In Mentor it is, but in another company, a moderate plus might actually have less projection than a moderate profile implant, because the companies haven't all agreed on what they're going to call moderate. They're not going to say, you know, a width to projection ratio of this is a moderate, and a width to projection ratio of this is of a high. There's no kind of standard. So they just thought in their own minds or in their own labs what they're going to call low and high and moderate. And it can be confusing when you are looking at photos as well, because, like, as I say, if they've had a moderate profile of a different make, that might have more or less projection than the moderate profile of the make that you're looking at. So it's an absolute nightmare, and it's a minefield, and it's difficult. And that's why I always say, you know, stick with your surgeon, do your research, be informed, but don't worry too much about these things, because it can be very confusing if you start thinking, wait a minute, of the Corsa or this one sounds perfect for me. I'm like, you don't have to go to a different, you know, all the implant manufacturers, the dimensions will be there. If you look at the dimensions of the implant you're looking at, there'll be one in a similar one in a different manufacturer, but it might have a different name. As I say, it might be called a moderate, whereas it's called a high in another company. It might be called a low, whereas it's called a high in the other one. So it is confusing, and I do appreciate that it is very difficult for someone who's thinking of having implants, because not only is there a situation where we kind of don't know what it's going to look like I said earlier, a bit like the weatherman. But also, when you do research, you will get on the internet and see things which may not be relevant to you. If you've spoken to a surgeon who's talking about a different make of implant, and you see someone talking about showing photos of, look, this is a moderate plus, this is a high, I'm like, well, forget that, because that's Mentor. Those are different implants, they're different dimensions to the implants you're looking at. I've shown you photos of the sort of implants and the sort of projections of the implants that I use, and that's what you want to focus on. So it is not straightforward. I do acknowledge, and what I can do and what we can do at the clinic is do our best to help you to come to a reasonable decision. Basically, that's what you've got to get to, a reasonable decision. And, you know, and also remember, the implant's only one aspect of the whole thing. So obviously it's an important aspect. I'm not trying to say it's not important, but it's not. Do you know what? It's not actually as important as you might think. Certainly, once you've got into a moderate and, you know, certain width and height and what have you, there's nuances between them, and it's not as important as some people think, and it is difficult. People do get tied up in knots and what have you. So it is a difficult one. Now, I think something's happened on. Let's see what I can do here. God, people have been saying stuff, haven't they? Sorry, I can't see it when I'm got my phone bent. I thought this bent phone was a good idea, but now you're well. Oh, do you? Oh, hold on a minute. Is the projection? Crikey, where am I? What do you think about a teardrop B? Okay, yeah, I've done that. What do you mean by different profile implants, please? So yeah, so they come as different profiles. So profiles, so there's come in two shapes, a round and teardrop. So there's two shapes, and they come in different profiles according to how much they stick out. For, as I say, for a given width, some implants stick out more than others. So you can have a low profile, moderate profile, high profile, extra high. As I say, that's one of the companies' way of describing it. Other companies call them different names, like, you know, moderate and moderate plus and high and ultra high instead of extra high. And, you know, they don't have a low. So the names are different, but the principle is some stick out more than others. So what you've got to look at when you're choosing an implant is the shape is really important, teardrop or round, and the profile is really important, how much it sticks out. So look at some photos. This is how we do it. Look at some photos of people who've got them in with different, how much they stick out. And once you've got an idea how much you want it to stick out, we measure the width of your chest. And if you want an implant that sticks out like a moderate profile, say, then that will come to a certain volume. So we don't focus on the volume first, whereas most patients do focus on the volume first. So that is the profile thing. It's the projection, how far out they go. Okay, Peony's answering. Nice, that's what we want. Bit of internal. Good, that's what we want. Doctor, how much do you charge for a consultation, please? And is, oh Christ, my keyboard's come. Oh no, sorry, hold on. How much do you charge, that's it, for a consultation? And is there any technology you have where you can see a potential healed outcome before you commit? Do you try on sizes? So how much do I charge? I think, I don't know. I think it's a couple of, I think it's 200, is it? Or 5? Anyway, it's a couple of £100 I charge. To be honest with you, I'm not doing much anymore. It's mainly the other surgeons in the clinic. I'm trying to like support them. They're 100. I know they're 100. And do we have any technology? No, we don't. We have looked at the technology, and the technology does exist, where you take a photo and you morph the photo with the different sizes of implants. I don't think, speaking to colleagues, I don't think it helps the surgeon choose, but it might help a patient to sort of get an idea of what they're going to look like. But it's never going to be like, you know, obviously, well, maybe not obviously, but it's never going to be like exactly what you're going to be like. But it might help, and I'm still on the fence with it, whether it helps or not. I'm not sure. But yes, we do use sizes. That's what we do in the clinic. We use sizes to get an idea of the volume, but that just really gives you an idea of the volume. It doesn't give you an idea of the shape, and the shape is really important. That's why we look at photos of people who've had it done to look at the different shapes. But the technology for me is not useful for me as a surgeon, although it might be useful for patients to see. I don't know, and I'm not 100% convinced on it, although I have spent many years looking at it. For many years, been looking at it. You're welcome. Also, if it helps you, I was a C and now I'm a double D with the teardrop, an extra high profile, and I'm really happy with my results 2 to 3 months post-op. There you go, Peony, real person. So right, so yeah, extra high profile teardrop, good. Okay, good. C to double D. There you go. Peony, £100 consultation fee unless it's increased, and no, but JJ will show you pictures, etc., to help along with sizes. Unless it's increased, and no. What's no? Oh, no for the technology. Yeah, show you pictures, and yeah, that's true, Peony. Very true. Very, very, very true. But 100, yeah. For the other guys, I think I've mine's more than that, but the other guys are brilliant. What's this with Staiano, Peony? What's JJ? I don't know if he's. I don't know if I'm behind on the chat. Have you had all this chat already? And I'm just recapping it all. JJ's me. It was with Staiano, and this is JJ doing live. Yeah, me. I'm JJ. JJ Staiano. That's my name. Oh right, okay. Thank you. Do they work together? No, I am JJ Staiano. I'm both of them. I'm JJ and Staiano. Yeah. Oh God. I think I'm behind. I think this is. I don't know if this is looking bad because I'm. Oh, we're up to speed. You're welcome. We have. It's the same person. It's his practice. Yeah, JJ Staiano is my name. But I've got other surgeons, not Peony, Omi Akani. I've got other surgeons, and I'm only treating a small number of patients these days. So yeah, but we do have sizes in the clinic. To give you an idea, what's what? What was that? Yeah, you did my friend's mum, Maria Patti. Yes, I'd like to have you personally. Oh, yes, I know. Yes. Oh, your friend's mum. That's nice. Right. Okay. All right. So there we go. Right. That's good, isn't it? That's good. That's a good one. Good one. Good one. Omia Kiam. Can I have breast implants if I have COPD? So COPD is chronic obstructive pulmonary disease. I mean, usually, I don't know if I'm being, I don't know if the COPD community will backlash on me, but usually COPD is kind of like an older demographic. And so breast implants in patients with COPD is not a common occurrence, but just because it's not common doesn't mean it shouldn't be done. So that's the first thing. What I would say is it kind of depends on how bad your COPD is. COPD can often be quite bad. You can be quite breathless. Sometimes you need oxygen. And so it might be the case that if your COPD is bad, then it might be a no, basically. But it's definitely a might. I mean, you might there are a range of severities of COPD. So if it's quite mild and you've got quite good exercise tolerance, if you can kind of walk up a flight of stairs and have a relatively normal life, you go to the shops, etc., then perhaps you could have it done. So it's not a definite no, but it kind of makes me think it might be a no, to be quite honest with you. But we would definitely, and we could just talk to you. We wouldn't have to have a consultation. We could just talk to you. And the other thing I often say to people with medical problems in general is to talk to their doctor who looks after the medical problems. So if you've got a doctor who looks after your COPD, maybe say, thinking of having breast implant surgery, what do you think? Because usually if it comes to it, I would take advice from them. I would take advice from your physician who's looking after your COPD, and as well as the anaesthetist. Really it's the anaesthetist who would be kind of like the final judge on that. But I would say it's not a common occurrence, people with COPD having breast implants. But it never say never. But I would be a little bit maybe a little bit negative about it, thinking that maybe we wouldn't be doing it. But we might, probably not. But you can always give us a call and we can talk to you and stuff. I guess we can maybe get an assessment of how bad you are and talk to the anaesthetist if you want, even before coming to a consultation, so you don't have to pay for a consultation and stuff if you want to have an idea, because you don't want you bringing to your consultation and paying for a consultation and then us telling you we can't do it. To be honest with you, if we did that, if you came for a consultation, paid for a consultation, and we said we couldn't do it, we would refund you the consultation, because if we say we won't do it, then we will refund the consultation. But I previously had a breast uplift and areola reduction with another clinic in March 2021. but I am not happy. Would you offer areola reduction? Yeah, yeah. Definitely. I mean, well, it's 2021 a few years ago, isn't it? I mean, what I was going to say is it's always best to go with the original surgeon, original clinic, because they might have a kind of incentive to do it for, not charge you full price for it. Whereas, we would charge you full price for it, but it's been a few years ago, so they might still charge full price. But yeah, for sure. And it's the reason I say that is because it's a risk with areola reduction that it can stretch out. Now, having said that, if you have a breast uplift with areola reduction, the risk is less than if you're just having an areola reduction, because if you're having a breast uplift, that removes quite a lot of skin, including the extra areola skin, but also some skin surrounding it to tighten the skin of the breast. So the tension is kind of distributed a bit more than if you're just having an areola reduction, which is just a scar around the areola, which is all the tension is around that areola scar. So the risk of stretch is more with an areola reduction than it is with a breast lift. So not that I want to kind of put you off, but when we do the areola reduction, there's different sort of stitches you can use when you do an areola reduction. So personally, I tend to use a permanent suture as we call it a purse string. It's kind of call it a wagon wheel design, but anyway, it's a stitch that goes all around the areola to take the tension off. We put it down deep, and that permanent suture makes it less likely to recur, because recurrence is a risk with areola reduction. It can stretch out because it's closed under tension, and there's a risk that it can stretch again. So that's always a risk, but we try and reduce that risk as much as we can. As I say, I use a permanent purse string suture to try and reduce that risk, but even so, there's always a risk of stretch with that. But I don't want to put. Having said that, I don't. Yeah, the answer is yes. We would be happy to see you and offer another areola reduction for you. Absolutely delighted to see you. That's the answer. That's the short answer. What is the healing time for a breast lift with implants and full tummy tuck with liposuction? Well, the healing time is, I mean, that's big, isn't it? That's the sort of stuff that I do. That's kind of big. I was going to say the biggest you can do, but I suppose going all the way around tummy tucks is the biggest, but that's pretty big. It's up there. It's top end. That breast lift with implants and a full tummy tuck with liposuction. That's top end. So but at the end of the day, scars are scars. So the scars are all going to take the same amount of time to heal than if you were just having like one on its own. But obviously, there's more kind of length of scar, if that makes sense. So there's more risk of something breaking down because there's so much of it. Whereas if you just had your breast done, there's less scarring to break down. Does that make sense? Because if you're breast in your tummy, you've added another length which can break down. So it would be the same if you'd had them done separately, but you're just adding them together. Anyway, okay, so let's answer the question. Stick with the program. What is the healing time? The healing time, so dressings all sorts on for a week. First week, you're going to be all bent over because of the tummy tuck. The tummy tuck's probably going to be the overriding thing. The breasts are going to feel tight. You're going to feel tired because it's going to be long anaesthetic, that. So yeah, tight, bent over, uncomfortable, and what is it? So that's the first week. Second week, you have the dressings off. Usually you don't need any dressings after the first week. Sometimes you do, but usually you don't. And then second week you'll be doing stuff around the house. In fact, you'll be doing stuff. You'll be potting around the first straight away because you're not getting a DVT, clots in your legs. So you're potting around straight off the bat. But second week you'll be potting around a bit more. If you have to drive to work, I normally say 2 to 3. Well, for that I'd say 3 weeks. Before you'll be starting to drive short journeys and things like that. So I'd say at least 3 weeks for driving, mobilizing, getting about after a couple of weeks, and then nothing heavy in terms of lifting for 6 weeks. And in terms of the shape and the scar and the etc., 3 months before it starts to settle. The shape, especially with the breasts, they look a bit odd when you do a breast lift with implants. And it takes a good few months for that shape to settle. So yeah, the healing 6 weeks, the shape and the scarring 6, 12, 18 months. So not a lunchtime job. I'm just gonna have a look, see if anyone said anything on. What's it? You did my. Oh, I've done that. Oh, right. Okay. Mrs. Glow, I did your question earlier. Thanks for the question about the explant thing. I don't know if you were here, but do we offer hip dip filler treatment? Yeah, someone asked this the other day. I don't know if that's why they put it on. There's stuff on the internet, you know. I don't know if that's on the internet. I don't know if people out there know what that is, hip dip filler treatment. I mean, but I guess the mere fact that I'm saying that kind of gives you an idea of the level of expertise I've got in hip dip filler treatment, i.e. I'm not an expert in hip dip filler treatment. I mean, at the end of the day, if someone's got a dip in their body and they want it filled out, you can fill out a dip in the body with fat graft. So you can fat graft a dip in the body, or you can fill a dip in the body. But this hip dip, I said no. I couldn't help this patient, and I think I would say in general terms, if there's a, you know, if someone's searching for hip dip filler surgeon, I don't think I'm going to come up. So yes, you can fat graft anywhere. I didn't even know it was a thing. I'll be completely honest with you. I didn't even know it was a thing until a patient asked me, and I'd say, what do you mean? And then she showed me, and I'm like, okay, there's a bit of a dip there. I guess I could fat graft it, but it's quite a big deal doing fat grafting. And I'm, you know, I wasn't very positive. Basically, there's probably people out there. Maybe there's people out there who do fit hip dip filler specialists. I don't know, but clearly it ain't me. So I guess the answer to that is no. I would say I don't do hip dip filler treatment. Although having said that, if there's a dent somewhere, if there's a contour irregularity, you know, fat grafting is quite a main part of the practice. Well, actually, it's not. It used to be, but it's not at the moment. But I, you know, used to do a lot of fat grafting, so fat grafting can be done. Right, let's just say no, we don't do a hip dip filler treatment. Nicola, what you got? Do you recommend lymphatic draining massage after a tummy tuck? If so, how soon after and how often? Good one, Nicola. That's a good one. I would say I don't know. I don't know. People talk about it and they say it's good, and I could imagine it being so. Do I recommend it? So answer the question: do I recommend it? No. I don't not recommend it, but I don't say routinely to my patients, you got to have lymphatic drainage massage. And that might be because we haven't got a link with a practitioner. I don't know if there's any evidence to say there's any long-term benefit in it. There might be a short-term benefit in it. And I can imagine that it is quite nice to see someone and to have some kind of treatment. I don't want to belittle lymphatic drainage massage people. To say that they don't have any effect, because I'm not saying they don't, but I think the fact that you're just seeing someone and they're kind of laying hands on you, I don't think we should underestimate that benefit. But I'm not sure if there's any scientific evidence for the long-term benefits of it. Short-term, maybe there's some short-term benefits in terms of swelling. So I've got no problem with it. And if someone says to me, should I have or can I have it, I'd be like, yeah, go for it. Let me know how you get on. For sure. I don't think there's any harm in it, put it like that. I think, I mean, obviously you have to pay for it, so there's that element. How soon after and how often? That's the people who provide the treatment have varying opinions on that. But I think there's something to be said for straight away. You know, day one, day two. Obviously, it's going to be uncomfortable, so it's going to be very gentle to start off with. But you know, there's certainly going to be swelling around that time. But as I say, we don't routinely have a practitioner that we work with, and we don't routinely kind of recommend it or send people to it just because there is a cost associated with it, and I don't know of any long-term evidence to say that, you know, long-term you're going to have a better result from it. Although you might say, well, I'm happy just having a short-term benefit, and I'm happy to pay for that short-term benefit. Okay, well, fine. But so I don't know. I don't have a lot of experience of it. So I don't feel that I can say yes, it's really good. I certainly can't say yes, it's very bad, because I haven't heard bad things about it. But I don't know if it's the problem with us. You got sometimes, especially in the cosmetic world, I feel like you've got to kind of bridge a bit the gap between the doctor and the science and everything, and just kind of helping people and giving them advice. And I think sometimes as doctors, we maybe are a little bit giving people a disservice by being a bit too much like, no evidence for that, cannot recommend that at all, which I've just been with the lymphatic drainage question in hindsight, because sometimes I think it helps. Like when people want to massage scars, we say, look, use whatever you want. We got some stuff, we got some QV cream and stuff we sell, but you don't have to use that. You can use Nivea E45, whatever. There's no evidence to say one's better than other. From a kind of medical point of view, that's kind of good. But is that good from a patient point of view? Is it better to say to the patient, what you've got to do is you've got to massage it 3 times a day in this way, and we've got to use this QV cream we've got. It's actually brilliant cream. It's fantastic. It really helps to moisturize that scar. And and if we're a bit more positive rather than being no evidence for any cream being better than another, I wonder if I should have done that with the lymphatic drainage question. Well, we don't offer it, but yeah, probably do. If we start offering it, probably have to be more like that to say, like, yeah, it's really good. But anyway, just reflecting on my own inadequacies there. So thanks for that, Nicola. So yeah, go for it. And if you do go for it, let me know how you get on. But no, we don't routinely recommend it. But that's probably more out of ignorance is the wrong word, lack of knowledge, than any knowledge to the contrary, like that. Because like everything kind of doesn't work until it's been proven to work. Nothing works. The default position is like nothing works until you prove it works. And that's where I am with this. Someone say, oh, you got to have this, you got to have that. I'm like, okay, well, it sounds good, sounds nice, but can you prove to me that it works? Can you get 100 patients and lymphatic drainage half of their abdomen and not the other half, and say that they're going to get a better, you can't, can you? You're never going to get that kind of proper randomized controlled trial, which is what kind of doctors are looking for. But maybe as a patient, you don't really, you're just happy to have something that might be beneficial, kind of thing. And as long as we put it like that, it might be beneficial. You might say, oh well, yes, please. Right, okay, so there we got full circle. So yes, go for it, lymphatic massage. Thank you. You're welcome. You're welcome, Nicola. Good luck with that. Let me know. Right, what would happen if you don't stitch the skin after a tattoo excision? What the heck question is that? What's that? That smacks of someone who wants to cut their tattoo out and not stitch the skin. Well, so if you do a tattoo excision, so if you actually cut that full thickness of skin out, as opposed to something like dermabrasion, where you kind of just get an angle grinder or dermabrader, but kind of like just take the top layer of the skin off. So if you're just taking the top layer of the skin off and you're leaving some skin behind, then that skin will heal a bit like a skin graft donor site heals. You just take the top half of the skin off and that skin will heal. But if you're doing a proper tattoo excision, so you're taking the full thickness of the skin, which is what you do with a tattoo excision, and you don't stitch it, then it will heal by what we call secondary intention, which basically means healing from the sides across. So when you do a partial thickness injury or wound, like a dermabrasion, or as I say, a skin graft harvest, or a burn, for instance, a not a full thickness burn, because there's some skin left behind, that skin will heal from what the skin that's left behind. So it will heal relatively quickly. It'll heal in a week or so, that skin will be healed. Whereas if you've got, and it doesn't matter how big that injury is, really, a skin graft donor site, theoretically, a very small skin graft donor site versus a very big one should heal in the same amount of time. Now, obviously, a very big one's going to have more areas where you're going to prone to little bits that don't heal. But on paper, theoretically, they should heal in the same amount of time because they're healing from the base up. Whereas a full thickness wound, a bigger wound is going to take a lot longer to heal than a smaller wound because it's got to heal from the sides across. The skin's got to come from the sides across. It's not coming from the base. So it'll heal by what's called secondary intention. Now, small wounds can heal quite well from secondary intention. Sometimes if you take moles off or something like that, or you do some kind of skin excision and the wound opens up, and the patient goes, oh my God, it's opened up, it's terrible, you've got to restitch it and all that. Personally, I pretty much never restitch it because you worry about stitching infection and stuff. So you usually leave it, and it often heals really well. And you think, crikey, what did I bother stitching it for? Now, it takes a bit longer to heal, but it can heal really well for a small area. But tattoo incisions are not normally small areas, but small areas can heal quite well. You have to keep them moist, keep them clean, and let the favour for the wound to heal. But yeah, that is what would happen. It would heal by secondary intention. The other thing about healing by secondary intention is that volume of scarring will be greater. Now, again, when these wounds, when these moles and things break down and open up, the scarring can be pretty bad to start with, but it does actually shrink and it does contract, and it's often not as bad as it looks to start with. So not that I'm encouraging people to excise tattoos and not stitch them up, but you know, for small wounds they can actually not look that bad, but for a bigger wound you would not want to leave it. Like what normally says, like anything bigger than a 50p piece is just going to take absolutely ages to heal. So you wouldn't really want to not stitch them up. It's gonna, because if you stitch it up, it should be healed in a week. Should be, not always. But if you don't stitch it up, then it can take literally months, absolute months, if you have a big wound, and it's completely not worth it because there's a risk of infection and all sorts, and you have to have dressings during that time. So there's all sorts of issues with it. So not recommended. So that is it. I am out. What's happened on the gram? Has the gram gone quiet? Yeah, good. Right. So what we're saying now is we're saying that, oh, that's how you get rid of the keyboard. New Lives in the Wild. We reason to believe. Is it 9 o'clock? It's on 9 o'clock. So bit of dinner, a bit of New Lives in the Wild. I don't know what you're doing. Please write in. Please text us with what you're doing this evening, and I will see you here, same time, same place, next week, and it's February next week. So yeah, thanks for joining. Thanks to Nicola. Thanks for Peony. Thanks for everybody who contributed. Omia Kayam as well. All your contributions very gratefully received, and not underestimated. Anyway, see you next week. Stop the stream.